Good morning. How was your weekend? Oh, wait a second. Sorry, I forgot. You guys aren't sitting in front of me. It makes it a little bit harder. You guys are starting your studies in psychiatric nursing today. And the topic that we're going to cover today is probably the most important topic that you're going to cover in this course. And it probably will be significantly important throughout the rest of your formal studies in nursing as well. So let's get to it. Okay, so let's start this conversation with the basics. What are the different types of communication that you're familiar with or that you have been taught? Well, there's three specific kinds that I want you to know about. There is the spoken or the verbal, in which I may say things to you, certain words are used. Those are pretty self-explanatory, right? Then you also have the nonverbal, which in psychiatric nursing is probably one of the more important ways to communicate with your patients. You can tell a lot by somebody's body language or what they're not saying to you. You can tell when somebody's happy. You can tell when somebody's angry. You can tell when they're anxious or when they're frustrated. All those are nonverbal forms of communication, and they are extremely important, especially if you have a patient who is psychotic, or maybe you have a patient who has dementia, who has difficulty with being aphasic. And then you have the last one, which is going to be the one that is the most challenging for you as a student and even as a young nurse, which is the therapeutic aspect. In a therapeutic type of communication situation, this is always going to be ongoing. It's always developing. It's always changing. But this is through which meaning emerges. This is where we say something to an individual, they say something back to us, and there's a meaning that exists between the two of us. So what are the basics of therapeutic communication, since that's going to be such an important aspect of what we do in this class? Understanding, as I first stated, that there are several different types of communication is going to be important. And I can't reiterate enough that nonverbal is going to be the one that you're going to get primarily the most information from your patients. Remembering that if you're anxious, that you may make that patient anxious is also another concern. So make sure that even if you are nervous, that you take your time when you're talking to them so that you don't give them the wrong message, right? Your communication with them should be clear. It should be concise. It's great to talk about what the weather's like, or it's great to talk about the things that you did today or yesterday, but that's not really the purpose for you being there, right? So you want to keep it professional so that there's not any miscommunication that occurs between that. There are certain therapeutic techniques that will help you to be able to effectively communicate with your clients. And the more that you understand them, the more that you're able to recognize them, the better you'll be at being able to interpret what it is that they're trying to say to you. There are a whole bunch of them. There is summarizing. Summarizing means that you want to review basically whatever it was that they said to you, making sure that let me just summarize what you just said to me and repeating it back to them. Making sure that you're asking for clarification if you're not sure that you understand something. Rephrasing something. A lot of times those are ways that individuals miscommunicate with each other. All of these different types of therapeutic techniques are in your book, so I'm not going to spend a lot of time doing them. But I am going to encourage you to make sure that you learn them, because you're going to see them again. And the ones especially that you're going to see in the hospital setting are going to be important for you to have a good understanding of them. Asking open-ended questions is a valuable therapeutic technique. What do I mean by asking an open-ended question? An open-ended question means that you are allowing that individual the opportunity to be able to expand upon their answer. So if I ask you, how was your day today? You're going to answer me with, it was a bad day, or I was so busy today. It gives you the opportunity to give me more than a yes or no answer. Do we ever ask closed-ended questions? We do. We ask closed-ended questions when we need a very specific or a very direct answer. For instance, if we are doing a suicide assessment, I'm going to ask an individual very directly, are you having suicidal thoughts? Because I want them to give me a clear and concise yes or no. Do you have a plan? Yes, I do. No, I don't. So there is a time and a place for closed-end questions when we need very specific information, But more often than not, we want to employ those good listening techniques. So what about ineffective communication? Because truthfully speaking, we're probably way better at that than we are at effective communication, right? So what are some of the things that we need to look out for? And this is something that even after 9 years of experience as a psychiatric nurse that I struggle with on occasion, one of the biggest no-nos is when a patient says something to you or when you're in the midst of a conversation with them and you ask them why. Don't ever ask them why. First of all, you're not in a position to judge them. Second of all, it does put them on the defensive. They automatically think that there must be something wrong with what it is that either they're doing or they're saying or they're thinking. So what would be better to say to them? Can you share more with me about that? Would you mind telling me a little bit more about that? Could you explain that a little bit better to me? Never, well, why do you feel that way? Why did you do that? Being very careful about that. Challenging is also something that, especially as new nurses in psychiatric care, that we find ourselves doing. You're going to have different values. You're going to have different cultures. You're going to have different morals with a lot of these patients. You may not approve of some of the things that they do, but it's going to be really important that you, as I like to say, check your feelings at the door. Understand that these individuals, that they have the right to think and to do as they please. So not being judgmental is going to get you much further with them than making them upset or, like I said, taking a specific side against them. Something that nurses are really notorious for, providing false reassurance. We really want to tell people it's going to be okay. And the reality is that we don't always know that it's going to turn out just the way that it's supposed to. So don't provide that, don't give that false reassurance, because that is extremely ineffective as far as communication is concerned as well. So you're going to hear us talk a lot about the nurse-client relationship. How do we develop that? We make sure that we're open and we're honest with the individuals that we're trying to develop that relationship with. We do a lot of listening. We allow them the time to be able to talk to us about whatever happens to be bothering them or about what's going on in their lives. So you got to be a good listener. We don't do a lot of advice offering, making sure that that we're really there as a sounding board for them. So see, I'm going back to the whole listening thing. We do a lot of listening. So you got to be a good listener. Confidentiality is a big thing. Making sure that whatever is told to us in our presence or in the privacy of our office or wherever we happen to be, that it's not going to go anywhere. Not to mention the fact that that's a HIPAA violation, right? But more importantly than that, it's going to impede the trusting relationship that you're trying to develop with that individual. Holistic care is another aspect of the nurse-client relationship that's really important. So in other words, not just providing them medical care or psychological care, but we also look at their environment that they come from. We look at their living situation. We look at their sociocultural position. Do they come from a very poor family? Are they unemployed? Are they homeless? Do they have a supportive family? Do they attend church? Are they a drug user? All of these things encompass an individual's either mental health or mental illness. And probably the most important thing, or at least one of the most important things when it comes to developing that nurse-client relationship, is truly setting boundaries. That's tough sometimes. We don't have relationships with them outside of work. We make sure that we are professional with them. We make sure that they understand the limitations and what our expectations are, and we make sure that we hold them to that. So the phases of the therapeutic client or the therapeutic nurse-client relationship can actually be found on page 119 in your book. There is the pre-interaction phase, and I want to tell you that that's not actually in your book. So I hope you're watching this video. The pre-interaction phase is truly where you're getting a picture of the client before you actually see them. You're going to be looking at things like demographics. You're going to look at where they've come from. Do they have children? You're going to be their address, different things like that. You want to look at any kind of pre-existing information that you have on the client, which in some cases may be none. But it's during the orientation phase where you guys are getting to know each other that this is the time that you're going to be more guarded. You're going to be more anxious, but you are going to make sure that this is where you set your boundaries, your expectations. You're going to make sure that they understand from the very first time that you see them that this relationship is going to come to an end. So you're preparing them for the last phase of the nurse-client relationship from the very first time that you see them. You're also going to make sure that this is a point where you are talking to this client about what's most important to them. What is it that is most important? What do you need to, or what would you like to get out of this relationship between the two of us. The second phase is the working phase. This is the hard part. This is the part where we actually start to see some resistance from our patients. Patients are initially, they're very cooperative. They're going to take their meds. They're going to do what we ask them to. But then when we really start to get into the nitty-gritty of what it is that's been going on with them, we find that they start doing some of these defense mechanisms like blocking. We get to a tough topic and they all of a sudden change the subject. They don't want to talk about that. And so they'll stop talking about it. The working phase is hard. You may also find during the working phase that the goals that the two of you develop together initially are not the ones that are really the issue here. And so you may find that you need to change those. The last phase is the termination phase. In the termination phase, it is, of course, supposed to be a happy time. We've reached our goals, or at least we've made progress towards them. And it's important that you discuss that progress with them. It's also important that we talk about where you go from here. Are there going to be community resources that they're going to be able to seek out? Do you want them to continue therapy, to go to group? What are the things that they need to continue it? It is not uncommon to see regression at this point, to see where they might start to have some of the symptoms that they had gotten over or that they had been able to manage and to cope with. Maybe they're not quite ready or they're anxious about terminating this relationship. Very important. And I can't say this enough, is that through each one of those phases, especially during that working phase, you still need to make sure that they understand that this is a temporary situation. At some point, this is going to come to an end. One of the things that you need to become really familiar with when you are preparing for your interactions with your clients, and I'm really hopeful that you'll get to do a significant amount of that this semester, is preparing yourself and understanding and being able to identify the different types of coping mechanisms, or what we call defense mechanisms. Now, you can find a complete list of your defense mechanisms on page 115 in your book. I believe it is table 9.4. You'll find all of them. So what are some defense mechanisms? Some familiar ones. Rationalization is a good one. Clients try to rationalize why that they're doing the things that they're doing. Suppression is another one. Suppression, a lot of times, it simply means that something may happen and they don't want to talk about it right then, so they just push it back to the back part of their mind. This happens a lot. You see this a lot. Regression, we already talked about that. Dissociation, where an individual completely dissociates themselves. They talk about that they are a completely different person. Acting out is a big one. Clients who get frustrated or who have difficulty with stressful situations a lot of times will act out. And then when they're acting out, you'll see a whole lot of denial. I didn't do anything wrong. Make sure that you spend a little bit of time looking at those defense mechanisms. You'll need them for your paperwork, but you're also going to need them for test purposes. Let's sidestep just a little bit while we're doing this, and let's talk about family for a second. Family, when it comes to psychiatric nursing, plays a big role in an individual's either health or illness. Remember that family should always be included in whatever you're doing with the client, whether that is outpatient or whether that they're inpatient. You should be educating them on signs and symptoms of the patient's disease process. You should be educating them on their medications. This is an effort to make sure that they stay compliant so that they know what to look for before the problem becomes a psychiatric emergency. So families need to be included in that. Families a lot of times have great insight. Clients who come in that are suffering from psychosis oftentimes are not able to give us any kind of a background or any true perspective about what's been going on with them, but their families can. So always be respectful of the family. Always make sure that we're including them in everything that we're doing as far as patient care, as long as the patient is okay with that, unless, of course, that patient isn't able to make that decision themselves. So we talked a little bit about communication, the difference between therapeutic or the types of communication that exist. So now what we want to focus on is we want to look a little bit at the mental status, or actually the mental health assessment itself, because it is a little different. Are you still going to do a head-to-toe assessment like you did in health assessment? You are. But there is another component to that, what is called the mental status exam. What you need to know about the mental status exam is that it is a measure of that individual at that particular moment in time. Not tomorrow, not next week, but right now. So does it change rapidly? It can. We do mental status examinations every single shift, just like we do regular assessments. Mental status exams have different components to them, which is they're going to be important for you to be able to differentiate and to be able to identify and gather information to be able to fill that out completely. So the psychiatric or the mental health nursing process is the same as the nursing process itself. But there are a few things that we talked about a little earlier when we were talking about therapeutic communication that are going to be important for you to remember here too. You need to make sure that you know when to ask open-ended questions and when you need to ask closed-end questions. You need to make sure that once you ask all the information that you have attempted to collect, that you summarize. You go back over all of it to make sure that, first of all, that you understood everything they told you, and second of all, that you didn't forget anything. So that's always really important. State the purpose. You want to make sure that you're telling them why you're doing this. I need to have a better understanding of your history. I need to have a better understanding of what's been going on with you. That's really important. All of those are a little bit different than how we do just a regular assessment. The very first component of an assessment that we're going to look at is we're going to look at current and past health history or status. The same thing that we do in a physical assessment, but we're going to be looking at this particular area because in psychiatric or mental health, oftentimes an individual who is suffering an exacerbation of their illness might have something medically that's going on with them. And if you fix the problem that is medical, then guess what? Their psychiatric problems go away. So we're going to ask them about their neurological system. We're going to ask them about their endocrine system. We're going to ask them about cardiac. We're going to ask them about all of the body systems, just like we would in a regular history and physical. The only thing that is a little bit different is that we are going to ask about their current and their past use as far as substance abuse is concerned. Do they drink? Do they do any kind of drugs, prescribed or illegal? So that differs a little bit, but that's also really important. It gives us a better understanding of what their history is as far as substance abuse. So what other parts of an assessment are we going to look at? Well, we're still going to do a physical assessment. In the physical assessment, of course, we're still going to look at things like our body systems. We're going to look at neurological status, as I mentioned a little while ago. We're also going to look at lab results. Lab results are another area that for a patient who is suffering from an exacerbation of mental illness can sometimes be the reason that they're having the problems that they are. For an individual whose thyroid is out of whack, their thyroid is too low or it's too fast, it can cause them to be manic. It can cause them to be very depressed. So those are important things that we can get simply by looking at labs. We're going to look at their medicines. We call that a pharmacological assessment. We want to know primarily, of course, about their psychiatric medicines, but we also want to know about any other medications that they're taking because, again, we want to make sure that none of them are interacting. There are some psychiatric medications that a patient has to have that can affect their thyroid. So we want to make sure that they're on a medication for their thyroid in those instances. Physical functions, we're going to look at things like how well they're sleeping. Are they eating well? We're going to look at their elimination. Are they using the bathroom effectively? We're going to make sure that we're addressing things like self-care. Do they take a bath every day? Are their clothes clean? Do they appear to be well kept? We're even going to look at things like their sexuality. Have they lost the desire to participate in an intimate relationship? Or are they hypersexual and they just want to have sex with everybody? Those are important things that we need to know. This is a mental status exam. You are going to complete one of these for every psychiatric patient that you see, whether it is an outpatient or whether it's an inpatient setting. So you need to know the different components that are on this mental status exam. You're going to look at general observation. You can tell a lot about a patient simply by looking at them. Are they clean? Are they dirty? Do they have body odor? Are they disheveled in appearance? Those are just general observations. And you can start getting those as soon as they walk in the room, or maybe you're the one walking into the room. The orientation, are they alert and oriented to themselves, to place, to time? You're going to look at things like their memory. Are they able to tell you their birthday, Are they able to tell you who the President of the United States? Can you give them a series of numbers and have them repeat them to you to check their recent memory? We're going to look at their mood and affect. So their mood is how they present to you. Are they depressed? Are they angry? Are they sad? Their affect is a display of that particular mood. So they may be labile, meaning that their mood is going from them crying to being angry to being happy to being sad. We may describe their affect as being restricted. For an individual who has a restricted type of affect, that may mean that we tell them that something that would normally be devastating or very upsetting, for them, they may respond with very little emotion. Their speech, what is it like? An individual who's manic is going to have very rapid speech. We call that pressured. They will speak extremely quickly, almost like they can't get it all out. Okay? An individual who's depressed, a lot of times their speech will be very, very slow. You may see that it is delayed in some cases. A patient that has dementia may have what we call stilted or delayed type of speech. You ask them a question and they may pause multiple times when they are answering you. And we look at their thought processes cognitively. We call that a cognitive assessment. Are they able to make simple judgment? Remember, you did this last semester, right? You did a neurological assessment. You asked them what they would do if they found a stamped envelope laying on the sidewalk. You asked them a simple proverb. It's raining cats and dogs outside. What does that mean? Those are checking their cognitive abilities. We look at their thoughts the way that they're displayed. Are their thoughts what we call disorganized? So do they jump from one topic to the next? Do they have what we call flight of ideas? Again, they're jumping from one topic to the next. Do they have what we call tangential thinking? Tangential thinking simply means that you ask them a question and they go off on a tangent and they don't ever come back to answering your question. And then you can have what we call circumstantial. In a circumstantial response, these individuals, you ask them a question, they're going to start to answer your question, but 5 minutes later, they're going to have gone all the way around the world before they actually got to your answer, if they've reached it at that particular time. Their attention and concentration. Are they able to pay attention to you? Do you notice that they're fidgeting? Do you have to redirect them multiple times? And the last thing is their insight. Insight simply means how good of an understanding do they have of their disease process. And we usually rate that as being poor, fair, or good. Someone who has poor insight probably doesn't think they're sick at all. There's nothing wrong with me. I don't know why I'm here. I don't need this medicine. Someone that has fair insight understands that there's something wrong with them and that they've got to take medicine, but they don't understand the long-term aspects of it, that it's going to affect their ability to be able to work or have a relationship with somebody. They just know they've got to do it. And then someone who has good insight, they're going to put all that together. They know they have a mental illness. They know that they've got to take their medicine. They understand why, and they know that they've got to employ certain coping mechanisms in order to be successful from day to day. All right, so the last component of the mental health assessment is going to include things like behavior. Okay, so their behavior, literally, how do they act? Are they cooperative? Are they uncooperative? Are they agitated? Are they aggressive? What is their behavior like? Their self-concept, how do they see themselves? All of us have a self-concept, and our self-concept is actually made up of our body image, our self-esteem, and our personal identity. And all of those things actually play off of each other, which makes up our overall self-concept. For instance, let's say that you have an athlete who has always been very, very successful. He's very good at what he does, he makes a lot of money, and he's got lots of friends. More than likely, he's got a pretty good body image. He works out, he does good. How does that body image affect his self-esteem? It makes him feel good about himself. He sees himself as valuable. And your personal identity, which is actually something that most people assign to you, he sees himself as being a valuable part of society. Now let's say that this particular athlete winds up having an accident and now he becomes wheelchair bound. So he loses most of his athletic ability, that he loses all of his muscle tone, and as far as his body image is concerned, he doesn't see himself the same way. Does that affect his overall self-esteem? Of course it does. And as far as his personal identity, does he see that his position has changed? It may not really have changed, but he sees it that way, right? So all of the self-concept, the way that the patient sees themselves, is important. It's an important aspect of the mental health assessment as well. We look at stress. Do they have a lot of stress in their lives? What are their coping patterns like? Do they drink? Do they smoke? Do they go to church? Do they exercise? Do they eat well? What kind of coping patterns do they have, both healthy and unhealthy? And it's important that you list both of those. That this patient exercises 4 days a week, he goes to church every Sunday, that he has lots of friends, but that he also does cocaine 3 times a week. Risk assessment. A risk assessment is determining the likelihood that they may be a risk to themselves or to others as far as injury is concerned. A suicide assessment. So asking that patient very directly with what a closed-end question. Are you suicidal? Are you having thoughts about hurting yourself? Do you have thoughts about hurting other people? You guys are going to use all of this information to do what? Develop a nursing diagnosis. This can be found, or at least a large percentage of them, on page 140 and 141 in your book. You'll find all your NANDA diagnoses under there. And what's the purpose of having a nursing diagnosis? Of course, to be able to develop nursing interventions, whether they are biological, whether they are psychological, or whether they are social, which encompasses that holistic approach. The last thing that we want to talk about before we close today is we want to talk a little bit about patient rights and ethics. Have you ever heard the term self-determinism? That is the ability for an individual to be able to what? To make decisions for themselves. Just because somebody has a mental illness does not necessarily mean that is eliminated from their ability. There are certain rights that patients with mental illness or mental health problems are entitled to. One of them is that they have the right to refuse treatment. A lot of people don't know that. A lot of people think that for someone that has mental illness that they have to do whatever their physician says. That's not necessarily true. They have the right to refuse treatment. Their ideas about what they need and what will work and what is good for them may be very different than what their healthcare provider wants for them. And it is their right to refuse that. Patients who have mental illness also have what we call advanced care directives in mental health, which allows them the ability to be able to make very specific requests about what they want as far as their care as it relates to mental health. So they may say that they don't want long-term injections, or they may say that they refuse to take antipsychotics altogether. That is their right, and as long as they have a healthcare proxy that can enforce that, if they happen to be incapacitated, they're allowed to be able to do that. What's informed consent? Have you ever heard that? We talk a lot about it, don't we? We talk about a lot of it in nursing in general, but what is it really? It's actually a legal procedure that ensures that the patient has a complete understanding of what's going on with them and that they have the ability or the right to be able to make an informed decision as to whether or not that they want a particular treatment or a particular care that is offered. This is actually a state law. All patients are entitled to this. It is based, of course, on competence of the patient. So if the patient is not able to make a decision as far as being mentally competent, then that is a little bit different. It is extremely complicated in mental health. To be able to determine whether or not that somebody is mentally competent can be a challenge, because just because somebody is different or that they have different beliefs, values, or morals doesn't necessarily mean that they're mentally ill, does it? It's important to know. Just because it's different doesn't mean that there's something wrong. Decision-making ability really is often compromised in patients who are acutely mentally ill. So informed consent is something that we really have to be careful about. We really need to make sure that we're taking very seriously as healthcare providers. What kind of treatments or what types of treatments have you heard of when it comes to psychiatric care? You've heard about patients being put inpatient or in the hospital, right? You've heard about patients that are able to go to what we call outpatient. That exists within the community that they live in generally. They can go to a mental health facility. Usually it's run by the county or maybe by a private individual where they can sit down, they can talk to a counselor or to a therapist, where their medications can be managed by a psychiatrist or by a nurse practitioner. You have heard of involuntary or commitment types of environments. In these cases, the patient isn't able to make decisions for themselves. We get what is called a court order, or we involuntarily admit them to an inpatient facility until such time that they're able to make those decisions or they're competent. Right? 72-hour holds is also something that we use a lot. In a 72-hour hold, that says that an individual will remain within our care, usually in an inpatient facility, for a minimum of 72 hours, which allows us time to be able to truly evaluate what's going on with them. Sometimes this happens with patients who come in voluntarily. They know that there's something going on, or they come in and perhaps that they are substance abusers. They come in and they say, you know what, I want to admit myself, I want to get off of these drugs, I need help. And then 24 or 36 hours into their stay, they start having cravings for whatever drug it is that they were doing. And so they tell you, I'm leaving. We have the right at that particular time, if they are a danger to themselves or to others, to be able to hold them for 72 hours, which allows us that time. And at the end of that 72 hours, we have two choices. We either get a court order to keep them there or we release them. And for some patients, actually, after that 72 hours, they've worked through a lot of those cravings and they're usually willing to stay. The important thing to remember about the different types of treatment that exist is that all patients are entitled to the least restrictive environment. So in other words, if you have a patient who is depressed but has absolutely no suicidal ideations, they have no plan, that they just really have been feeling down for the last month or so, treating them outpatient would probably be the least restrictive environment. Putting them inpatient in a lockdown facility because they are having feelings of depression is much too restrictive. That's not what they need, and it is highly untherapeutic for them. Privacy and HIPAA is also something that is important in the different types of treatment that patients have. You would be amazed at how many individuals will call up to a psychiatric unit and say, "Hey, is Joe Smith up there?" And I have to tell them, "Do you have a patient number?" And they tell me no, and I say, "I'm sorry, I can't give you any information about that." That is their right. The only time that we are allowed to break HIPAA is if there is a duty to warn. So in other words, if that individual is threatening to hurt somebody else, then we have a duty to be able to warn them about that particular situation. All right, the last part that we want to look at, I promise this is the last thing, is you want to look at ethical behaviors of nurses. We've talked about ethical behaviors before, right? You've talked about them since probably day one. The ethical behaviors that we know we are to be practicing throughout our nursing career include veracity, beneficence, autonomy, non-maleficence, justice, and fidelity. I'm not going to go through each one of these. You know what the definitions of these are: veracity, telling the truth, etc., etc. So make sure that you look at them, because I also promise you'll see those again. So at the end of every lecture, I am going to post key terms from that particular chapter or topic that we covered for the day. So be sure to take note of them, because you will see them on exams and it will help you to be successful in this class. Here we go. And that is, as we say, finito. So today we learned a little bit, or we learned a lot, right? We learned about communication. We learned about therapeutic nurse-client relationship. We learned about ethics. We learned about how to do a mental status exam and a mental health assessment. Those are all really important for when you get ready to do your patient interviews and when you do your inpatient rotations, which is why I usually do them first. So what are we going to talk about next week? Next week, we're going to talk a little bit about the evolution of psychiatric nursing. Talk a little bit about the stigma that goes along with mental illness, because unfortunately it is something that you're going to encounter on a daily basis. And we're also going to look a little bit at self-awareness. Be sure that you spend a little bit of time going through and looking at these slides. I've posted all of the PowerPoints for you, so they're available for you to be able to look at and to take notes and whatnot if you need to do that. If you have any questions when we do our online lecture, you can ask me those questions. Primarily, I'll be focusing on doing case studies. Have a great week, and I'll see you next time. I can look right into the lens.
Right into the lens.
Okay, that already screwed up. Sorry. All right, that's done. Oh my gosh, I just totally forgot what I was saying. Environmental, psychiatric. Damn, yeah. Oh, sorry. Period. Is that it?
Yeah.
We're not gonna do that again. Period. Totally just lost the rest of that. How do I do it again? Period.
Well, no, that was no pizzazz.
Period.
Is that better?
All right, that's it.